All right. Hello, everyone. Welcome back to another Monday Rafael Medina's subspecialty series. The focus of this session is primary care, and I'm so excited to learn from two phenomenal clinicians that we have from New York Presbyterian Columbia University Medical Center. And my name is Maddie. I'm going to be facilitating the session today. And I'm going to jump into introducing our phenomenal guest today. So our case discussant is Dr. Maria de Miguel, and she is an associate professor of medicine and a primary care general internist at New York Presbyterian Columbia University Medical Center. And she serves as the director of ambulatory education and an associate program director for the Columbia Medicine Residency. And her interests are in the care of historically marginalized people, motivational interviewing, and community health. So Maria, Dr. De Miguel, thank you so much for being here, and we're so excited to learn from you. I was wondering if you could share a little bit with the people listening how you developed an interest in primary care.
Yeah, thank you so much. I'm really excited to be here. This is a great honor. Thank you guys for inviting me. I have always really been interested in working in the community and did a lot of service work before coming into medicine and had lived abroad and done some global health work before medical school. And I really fell in love with the idea of working with people in their lives, like understanding their social situations, understanding their families, understanding how their health was impacted by their work, by everything that kind of goes into their life. And in medical school, I realized that primary care was the place that I could really be part of the community, learn about people, and impact their lives in a long-term way. So continued to really love that experience during residency in my clinic, and stayed at the same clinic where I did my training to be a faculty member. So I got to keep my panel from residency, which was very cool.
Wow,
And I really love my experience now as a faculty member in primary care as well.
that's amazing. Thank you so much for being here again. And I would love to hear what do you like to do outside of medicine?
I was actually before medical school, I actually also studied art. So art is a hobby of mine,
Wow.
painting and drawing. And I also have three kids. So most of my time is focused on being a mom right now, but
Yeah.
it's a joy. It's a lot of fun. So those are my two hobbies.
That that's amazing.
Yeah.
Well, thank you again. We're really excited to learn from all of your experience. And our case presenter today is Dr. Suraj Shah, and he is a PGY2 internal medicine resident at New York Presbyterian Columbia in the generalist primary care and advanced clinician educator pathways. And his interests include academic general medicine, diagnostic framework creation, peer mentorship, and pulmonary critical care medicine. So Suraj, thank you so much for presenting the case today. And I would also love to hear about how you developed your interest in, the generalist primary care pathway, and also what you like to do outside of medicine.
No, of course. Thanks for having me, Maddie. Thanks for everyone for being here. I'm super excited to present this case to Maria. I think when I first entered medicine, I thought about all the mentors that were really important to get me to the place that I am right now. And a lot of them were generalists and were in primary care. And I think of pulmonary critical care as one spectrum of generalists, primary care being the other spectrum. I really love physiology and seeing how physiology is manifested in different people and different populations. And I think we have a really big privilege taking care of a population that have really interesting physiology. So trying to pair this physiology with the underserved population is something that really interests me, and also love education. I think a lot of mentors that helped me get to where I am were phenomenal educators, including Maria. And so trying to hone these skills in residency is something that I'm really interested in and looking forward to. Outside the hospital, I love to play tennis. I love the sun. The nice thing about the hospital is we're right next to a nice outdoor tennis court at the base of the GW Bridge. So myself and our podmates love to go out after a long clinic or a long board month and play tennis over there.
Amazing. Well, thank you both. Well, what we might let's jump right into the case because we have a lot to cover. And I just saw the comment in the chat. Is everyone able to hear Suraj okay? I'm able to hear him okay. I saw someone mentioned, but I think I'm able to hear you, so I think we should be good to go. So Suraj, you can go ahead and jump into the first aliquot.
Excellent. So we're starting out in clinic with a 61-year-old gentleman. History of CAD, has had a remote four-vessel bypass surgery, suboptimally controlled diabetes as secondary to insurance issues that have limited the cost of his antihyperglycemics, hypertension, CKD, stage 3B with significant microalbuminuria, and obesity with a BMI of 38, coming in with abdominal pain. He presented for a follow-up visit of his chronic conditions with about 2 to 3 weeks of cramping abdominal pain. It's kind of all over his belly, but predominantly in the upper abdomen. Comes and goes without any clear triggers and occurs a few times a day. The most notable associated symptom that he describes is heartburn. Doesn't have any nausea or vomiting, and the abdominal pain isn't related to any specific food, activity. He avoids dairy at baseline, not having any constipation or bleeding. Was previously taking pantoprazole daily, but ran out about 3 weeks ago. And only other thing that he notes that helps is Alka-Seltzer. That helps quiet down the pain right after it starts.
Okay, great. Sounds like could be bread and butter medicine, but maybe there's something more interesting there. So I think you did a great job, Suraj, hitting a lot of important features that I would want to know about. And we can maybe go into some of his past medical in a minute. But I think from the get-go, you hit, the important demographics, 61-year-old man. So that's how I'm sort of starting to frame my picture of him. And I'm going to assume that some of the risk factors you mentioned will be relevant, but we'll come back to that. You also, defined abdominal pain as his chief complaint, and then started going into your HPI questions in a pretty systematic way. I like to use a mnemonic for my HPIs because it got kind of burned into my brain as a med student. I use old carts. I think sometimes people have other mnemonics. I know QPRST is another one, but I really like old carts. So you mentioned onset. It was about 2 to 3 weeks ago. And then it had been going on sort of intermittently since then, I believe. You mentioned location, sort of upper abdomen, and then maybe some reflux symptoms into when you say heartburn, it was something like a pain going up into his chest as well. Did he mention like water brash or like bitter taste in his mouth, like all the way up kind of
bitter acidic taste in his mouth? Yep.
Okay. So heartburn as well. You also mentioned some of the quality that was crampy, or that was like the characteristic, the crampy. The duration you said was sort of coming and going, so like short duration but frequent episodes. And again, characteristics crampy. And then alleviating or aggravating factors. You mentioned aggravating, that you couldn't pinpoint any specific foods. Was eating in general something that brought it on, or he couldn't quite tell?
No, in fact, he said that he was having a hard time eating because he was always having this cramping abdominal pain with some heartburn.
Okay.
But even when he did eat, it didn't get worse, and when he wasn't eating, it wasn't getting better.
Okay. So he was sort of avoiding food, but it wasn't necessarily one way or the other, it was there. Okay. And then in terms of, you said alleviating factors, he tried, was it Mylanta, did you say?
He tried Alka-Seltzer.
Alka-Seltzer. And did that do anything?
It helped to temporize a little bit.
Mm-hmm.
And before he was on pantoprazole daily, and that kept it at bay.
So he felt like the stopping of pantoprazole was part of the problem here.
Correct.
Okay. And you mentioned in terms of associated symptoms that he did not have nausea or vomiting, and no any diarrhea or loose stool,
No diarrhea,
and constipation,
no constipation.
and no blood in stool,
Correct.
or dark stool.
No blood in stool, or nor did he have dark stool.
Okay. And you mentioned there wasn't any trouble when he ate. There was no like dysphagia or difficulty with food going down or food getting stuck.
No dysphagia, correct.
Okay. Okay. And then to finish out old carts, radiation.
No
No.
radiation to the shoulders or to his chest.
Good. And we talked about timing, and then severity. Could he give it like a number or any
Yeah.
specific?
It was about a 6 to 8 out of 10 at its worst.
Okay. So it could be pretty severe, it sounds like.
Mm-hmm.
And yet the context of this was he was telling you about this in a regular clinic visit. It wasn't bringing him to the emergency room, which is, sometimes
I
relevant.
asked him, correct. I was like,
Not
what
that
brings you
we,
in today?
go ahead, sorry.
Yeah, I asked him, what brings you in today? And he shared that this is this abdominal pain.
Got it. Got it.
And Dr. De Miguel, I would love, as you're asking all these questions, I'm really curious, as your experience as a primary care doctor, what do you see as kind of red flags for abdominal pain in the clinic? Like how to distinguish from more benign versus this is something I should be more concerned about.
Absolutely. Yes. So I think when I think about red flags for abdominal pain, I think a lot about the acuity of the problem. So has this been going on for a long time? Is this relatively new? 2 to 3 weeks is relatively short time frame, but he was taking a PPI before that. So it's possible that something that he's developing now is flaring because he's not taking the PPI. But the time frame is relatively short, so that is somewhat of a concern. And then things like, we'll get to vital signs, and if there's any vital sign changes or changes on the exam. But from the history, the other things I'd be worried about would be sort of other signs or symptoms of acute events that could be life-threatening. So abdominal pain could be a symptom of something severe like a perforated ulcer, something like, or a bad enough ulcer that it could be relatively close to perforating, something like an obstruction, small bowel obstruction. So things like inability to eat or tolerate food, and nausea and vomiting that can't be controlled. Obviously bleeding, upper GI bleed, so any bright red blood per rectum or melena, dark stool would be concerning. Like red flag that something potentially life-threatening is going on. There are also other more severe forms of abdominal pain that would need more like emergency level care, in terms of blockages like cholecystitis, or I'm sorry, like a gallstone, biliary colic, but more of an acute episode where the biliary tract is involved. That could cause pretty severe symptoms. Other signs of like an acute abdomen, so pain with walking, pain with like like small movements, inability to get up out of a chair. This is where the context is really important, because someone coming to clinic with the pain means they could walk there. They were upright, they weren't obtunded, they were able to get themselves to clinic. So all of those are good signs that he's not acutely ill, although he could have something that's kind of ominous and looming. But the red flags that I'd be looking for an acute event, I'm not quite hearing. There are also vascular events that can occur that can cause serious abdominal pain. Things like syncope or feeling lightheaded, to imply somebody bleeding, or having some sort of, ruptured aneurysm or something like that. And then, other serious ailments. I mean, I think I could think of a lot of other terrible things, but I think, the acuity of the pain, um, the appearance of the patient at the outset, will give you a little bit of a sense of how severe, the whatever sort of internal event has happened or is happening is. But sometimes it can be subtle. I think that's why abdominal pain is a really good topic, because things can hide in the abdomen a little bit. And even though the story we're hearing so far hasn't included anything that sounds like a major red flag, I think it's a good, we still have more data gathering to do here. The other thing would be red flags for more, chronic problems that could be looming. So things like weight loss. We mentioned dysphagia, food getting stuck. Sometimes the change in the stool can also be like more subtle changes in stool caliber, things like that can be a little bit of a red flag that a malignancy could be hiding. So we'll see if we tease out any of those malignancy concerns.
Thank you. That was a brilliant overview of the red flags. Suraj, back to you for more data.
Awesome. So kind of rounding out the past medical history that he's had a history of acute gangrenous cholecystitis about 1.5 years prior to admission. He's had a laparoscopic cholecystectomy and no longer has his gallbladder. He's had a upper endoscopy done for persistent GERD or reflux about 8 years ago. And during that time, there were no ulcers seen. H. pylori was negative. Was started on a PPI and his symptoms resolved during that time. He says that the current pain that he's having is similar to these episodes of GERD he's had in the past. He's a never smoker. He's had parents who smoked at home every single day. Has no alcohol or other drug use, no NSAID use. And because of this prior secondhand smoke knowledge, he's previously had an abdominal screening ultrasound that was negative for an aortic abdominal aneurysm. And the last thing that I'll add to kind of round out the HPI part, he notes the 25-pound weight loss over the past year while he's been on Ozempic or sub-Q semaglutide. Recently, he's had some insurance issues because of the supply chain demand, and he's been unable to pick it up for the past 2 months. Otherwise, he's had no other medication changes or new medications during this time.
Interesting. Okay. So on the semaglutide, did he have worsening of GERD, or did he notice any GI upset or problems when he was using the semaglutide?
That's a great question. No worsening of symptoms, didn't have any kind of early satiety or worsening colic type symptoms when he was injecting with the semaglutide.
And he had quite a bit of weight loss, but on the semaglutide, so a little bit qualified there. Okay.
And Maria, I'm curious how this additional data that we got, the weight loss in the context of that medication and the past medical history, how is that influencing how you're thinking about the patient and the severity?
Yeah, I think weight loss is always an ominous sign. It's always something to take seriously, and I think sometimes there can be a little bit of sort of false sense of security that it's due to a medication like a GLP-1 agonist, something like semaglutide. Yes, it can cause weight loss, but 25 pounds is a lot of weight. And while some people can definitely lose that much weight on a GLP-1, I still would keep it as a significant piece of the history as we're piecing this together, in someone with, pretty severe pain, abdominal pain, just from stopping a PPI. Some people might get more reflux when they stop a PPI. And in fact, there can be rebound if you've been on a PPI for a long time and you stop it, you can get actually more acid production and therefore worse symptoms. But you mentioned like 6 to 8 level pain at times. It's pretty severe. You also mentioned he has some significant GI history. He has had a gallbladder surgery, which doesn't preclude further gallbladder events. So that's something to consider. And when someone's had a lot of weight loss, they can also tend to form gallstones um, more likely to form gallstones. So that's a possibility. You can have stones even if you don't have a gallbladder. So it's just something to consider. And then there's something else you mentioned that I wanted to bring back in. I mean, I think the other thing is we know he has a lot of vascular disease. We always have to consider, the referred pain from different vascular beds, things like acute mesenteric ischemia, or even just having an MI or unstable angina and having referred pain is always kind of looming in someone with this level of disease, but of cardiac disease. But I think the weight loss is making me pretty nervous that there could be something malignant or severe going on. The fact that he had an EGD in the past is somewhat reassuring, but 8 years ago is a decent amount of time. So something in the stomach or the esophagus, especially in someone with long-standing GERD, would be somewhat of a concern. Those are the things I'm thinking about.
Amazing. Thank you. All right, Suraj, back to you.
So I can go into the next aliquot. When going to the objective data, he was afebrile, hemodynamically normal, heart rates in the 60s to 80s, blood pressures was 120 over 80, and was satting over 95% on Rumare. His abdominal exam was very benign, no tenderness to palpation, no referred pain, all provocative maneuvers with lower extremity MSK testing was all negative, no peritoneal or guarding. His A1C during this visit was stable at 9.6. Initially we actually, I'll stop over here and kind of see what your thoughts are on this.
Yeah, and I'll just jump into, I'm just really curious, Dr. De Miguel, to ask how you think about, with this patient with this exam, would you proceed with imaging, close follow-up, kind of how would you proceed?
Yeah, great question. So actually I just thought of two other little history questions that I wanted to clarify. Any NSAID use?
No one said
have it
yes.
on his list, and he doesn't take, but he takes aspirin, I'm assuming.
He takes maybe aspirin.
And any other, we didn't go through his full med list, but any other like anticoagulants or anything like that, like for his
Plavix. He's on a beta blocker, a ACE inhibitor for well-controlled hypertension. Is on semaglutide, metformin, and Jardiance for his diabetes. And for his CKD, we talked about the SGLT2 inhibitor and the ACE inhibitor. He's on atorvastatin and ezetimibe. He's a familial hyperlipidemia gene carrier with well-controlled hyperlipidemia on these medications. And then was taking pantoprazole for his GERD, otherwise no other medications.
Got it. And in his social history, any alcohol use?
No alcohol use.
Okay. I mean, there could be a lot of other social questions, but I assume you'd mention it if it was relevant.
Well, it's he's a never smoker. He has significant secondhand smoke exposure from his parents.
Great. So yeah, at this point, I think the takeaways from the exam was that it sounds relatively unremarkable. One thing to consider is he is on a beta blocker. So when you're seeing someone and you're thinking, could he be losing blood? Could he be, having any kind of serious event right now? Being on a beta blocker is something to think about because it can kind of mask tachycardia, but that's a pretty subtle or a pretty important sign that something serious is going on in terms of bleeding. So I feel pretty reassured that his heart rate is normal, his blood pressure looks okay. And that's another thing I always like to think about blood pressures in context. If he's always 170s and now he's 120s, that could be low for him, but that looks like an okay blood pressure. He didn't sound like he looked uncomfortable. Do you remember when he's sitting there talking to you, not looking, nervous or, tremulous or anything like that? So those are all reassuring signs. Got up and walked around you, and also on your exam, you could mash on his belly. You really didn't elicit tenderness in any specific spot. So that is a pretty reassuring exam, I have to say. That's what I like to see as a primary care doctor, that I'm not feeling super worried that he needs to go to the emergency room. I think that's always our number one sort of, decision point when someone's telling us that they're having episodes of 6 to 8 pain. Is this an ER referral? Suraj and I are really lucky that our clinic is above the ER, so that makes our life a little easier. But still, then I'm thinking about next steps in terms of workup. And if I was going to, the way I like to think about abdominal pain, a lot of people use quadrants. I think quadrants can be helpful, although sometimes it's a little misleading if you just stick to the organs in the quadrants. So I actually prefer to think about sort of organ systems and which organ systems I think are involved. So if I think about like the GI tract from all the way down is one sort of system. The biliary tract and the hepatobiliary system is kind of another system. Then I like to think about like the GU, so like kidneys, bladder, that system, and the reproductive organs, and that's really pelvis. It's not exactly abdomen, although that's where you can get into trouble, right? If you don't think about ovaries, you'll miss ovarian things. So I like to think about the reproductive organs. And then you also have, again, the vascular system, which goes throughout. So you can have vascular events in lots of different organs. You can have the main or aorta, like to really think about the vascular system. And then there's more sort of obscure things, endocrine, neuro, hematologic problems that can cause abdominal pain. And then there's like associated diseases that can cause ascites, and ascites can have a whole nother differential. It really doesn't sound like he has ascites for any reason, even though he has cardiac problems and renal problems. So based on the story you're telling me and the associated symptoms, pain with reflux, I think we're talking the GI tract here. I wouldn't totally exclude the hepatobiliary system because there's some relationship to food, or at least he's avoiding food in some ways, and he's had weight loss. So if I were to say my number one bucket is GI system, and the one associated symptom we have here is sort of reflux. I'm putting my money on something in the stomach or in the esophagus. And therefore, I think there is some blood work that I think could help us here. I think I'd like to know if he's losing blood slowly over time. So I think anemia would be a really important lab. We didn't hear about pallor. He's not hypotensive and tachycardic. So if he is anemic, it maybe is like a more of a slow blood loss. I'd like to know about, infection, I think is low on my differential, but there could be obviously H. pylori as a cause for stomach pain. But so, white count, I wouldn't be too worried about at this point. I think that LFTs would be helpful here too, to make sure that, again, with his biliary tract, we know he doesn't have a gallbladder, but could there be some sort of obstruction of one of the biliary ducts? He's not jaundiced. We're not hearing about jaundice on exam, so that makes me feel somewhat reassured. Could this be a pancreatic lesion, pancreatic cancer, a stone in the pancreatic duct? That's a possibility. So lipase, I think, would be helpful. He doesn't drink alcohol, but he has some smoking exposure. I think we have to keep the pancreas in mind here. He's not vomiting, so acute pancreatitis doesn't sound likely. I think for my initial workup, a CBC, LFTs, and lipase would probably give us some clues. And then that would also help us sort of in our next steps to think about, do we need imaging? Do we need endoscopy? Because things like, a gastric cancer, esophageal cancer, ulcer, gastritis, esophagitis would all be pretty high on my list. Is that fair? Am I missing anything, Suraj?
No, can I give you some more data
Yes,
and like kind of go through the course, and then maybe we can build on that list as we go through the course.
perfect.
Um, so because he recently stopped the PPI, we figured let's retrial the PPI for about 6 weeks and have close follow-up, and have that workup in the back of our mind. So he gets discharged from clinic on 6 weeks of PPI, comes back to clinic after 6 weeks with worsening symptoms despite the PPI, and is now having retching sensations, and inability to tolerate anything PO. The semiology of his pain has remained unchanged. It's still this cramping sensation with associated GERD-like symptoms. But now he's having nausea and non-bilious, non-bloody vomit, to the point that he's been unable to keep anything down, and there are no clear triggers. During this, sorry, go ahead.
No, he didn't go back on the semaglutide, or he did?
He did not go back on the
Okay.
semaglutide. We've been trying to work with insurance, but he was unable to get the semaglutide during that time.
Great.
The abdominal exam during this repeat evaluation is notable for a very tender abdomen, predominantly in the right upper quadrant, and you could palpate the liver tip, and on inspiration, he feels that it's much more tender. This is all in the background of diffuse abdominal tenderness with voluntary guarding, and no peritoneal signs. So that's the extra data that I wanted to give you to see if your list changes, if that doesn't work up, and even if DISPO changes for you.
Yeah, I mean, this is definitely getting more interesting, because it sounds like, the initial sort of concern for just something from the stomach causing reflux, something where, reflux is really a product, not necessarily of overproduction of acid, but usually more a function of an insufficient sphincter tone. So a lot of times people are having reflux, more related to an issue relating to the sphincter. And if you give a PPI and that doesn't calm it down, the reflux, that could be, more concerning for a structural abnormality, or something that is really preventing that acid from or causing that acid to reflux. But the fact that so the PPI did not help, and he's having more dramatic symptoms now and more tenderness on exam is definitely concerning. That he has a more serious, like a progressing problem, and this time the tenderness is pretty focal to the right upper quadrant. So now we're kind of moving more towards the hepatobiliary system as our likely source of his pain, and or pain, and now inability to tolerate PO, which tells me that either and that nausea and retching and vomiting. So either there's something significant in the stomach, or pushing on the stomach, or causing the stomach to, be unable to like receive food, if that makes sense. It could also be, again, a problem with the biliary tree. It could be something hepatic. You did not say jaundice. He wasn't yellow on that exam, but he was very tender in the right upper quadrant. So a primary liver problem is a possibility. A primary source of hepatitis is a possibility. However, with the prominent gastric symptoms, I would think that something more biliary is going on. but I think all of those organs are at play here. So I think labs and imaging are pretty urgently needed. Did he lose more weight, by the way, in that 6 weeks? I would imagine if he's
Having
not tolerant.
ongoing weight loss. It was to the point now I think he had about 30 to 40 pound weight loss since the initial symptoms had started a few months ago.
Yeah. Okay.
And
Go ahead. Sorry.
oh, Maria, I'm just curious, at this point, would you refer this patient to the ED? Would you still continue his care outpatient? How are you thinking about that
Yeah.
aspect?
Yeah, the ED decision here is, I think, pretty clear because he can't tolerate PO. If someone's having such bad nausea and vomiting that they can't eat, that's a pretty clear indication that he can't go home. So for sure that he needs, a more aggressive workup, and he needs to be, more probably fluid resuscitated, but also more closely monitored. And really the workup needs to be expedited at this point. Yeah.
And then one last question before we give the mic back to Suraj for the next aliquot. I'm curious how you would be thinking of imaging modalities at this point. Of course, he's being sent to the ED, but what imaging would you select to start with?
Oh, for me or Suraj? Sorry.
Oh, for you, Maria.
For me. Oh, sorry. For some reason, I thought you said Suraj. So yeah, I think, you could start with a right upper quadrant ultrasound, to do something quickly in the ER, depending on, the hard part about a CAT scan in this situation is the PO contrast may be a challenge. If someone is retching, and really having a lot of, difficulty getting down PO. The benefit of the PO contrast is you can really see the full contour of the GI tract, in the sense that if you don't have the PO contrast, it can be hard to see, the cutoff point. If there's an obstruction, it's hard to see if there's anything that is intraluminal or sort of obstructing the lumen. But another quick test to make sure, I think small bowel obstruction would be pretty high on your list if someone really cannot take PO and has a tender abdomen. And so the first image would probably be just a plain film. A KBO can basically tell you, do you have an air fluid level? Do you have anything like that looks like obstruction? Then that can take, about 5 minutes once you get to the ER, and you're not waiting for the CAT scan. So I think I'd probably want to quickly make sure there's not, an obstruction with an X-ray, and then the either CAT scan or right upper quadrant ultrasound. I think the labs would help you a lot in that distinction. If you're getting very high LFTs, and this looks more either biliary in source or hepatic in source, of right upper quadrant ultrasound would be quite fast. If the LFTs are relatively normal, then I think I'd want a CAT scan. So I think the labs would guide me a little bit here.
Amazing. All right, Suraj, what happened next?
Asking if I'll receive. So he gets sent to the ED. For all those concerns that you're mentioning. The lab work is notable for a white count of 7.6, hemoglobin of 13.6, platelet count of 147. His basic metabolic panel has a sodium of 135, K of 5.2, bicarbonate of 26. Creatinine is 2.5, up from his baseline of around 1.8. His AST and ALT are normal at 27 and 34, and his alk phos is normal at 80. His total bilirubin is normal at 0.8 with a direct component of 0.3. His lipase was also normal at 80. And his hepatitis serologies for hep C was negative for the antibody. The hep B surface antigen, core antibody, and surface antibody were all negative. And the hepatitis A IgM was also negative. His urinalysis showed some glucosuria, but no hematuria or pyuria. And since the LFTs were normal, let's go down the path of the CTAP. Similarly, because he couldn't take anything PO, they did a CTAP with IV contrast. And it did show a new 4.8 centimeter pancreatic head mass with pancreatic ductal dilatation and significant mesenteric lymphadenopathy and possible colitis.
That's not good. Unfortunately. Curious that if was there a lipase right in those first labs?
There was, and it was 80, so it
Oh, you did
wasn't
say that.
remarkably
Sorry.
elevated. Mhm.
It was not remarkably elevated. So, really interesting case and kind of drives home the point that the LFTs being normal, the lipase being, pretty unremarkable, kind of belies the fact that something very serious is going on in the pancreatic head. And so the pancreatic, duct being there is not giving us the clues that we look for to think pancreas. And I think that's why, pancreatic masses can often be so subtle and difficult to diagnose, because if you had checked these LFTs a few weeks earlier when we first saw him, they would have been normal. There wouldn't been like an obvious clue there that we needed to do imaging right off the bat. So the weight loss is, an important factor here to keep an eye on. Again, it's really hard to know, when weight loss is an important feature, but it seems like in this case, that was one of the few clues we had to what was going on. And then, I think at this point, we can talk. I don't know if you want to talk more about diagnosing or sort of management, but if there's a mass in the pancreatic head, we probably have our answer about what's going on, because it well could be causing all of these symptoms. And the CAT scan is not diagnostic 100%, but is pretty close to diagnostic when we're talking about pancreatic cancer. Unless they, usually on the CAT scan, they can tell you there are other types of pancreatic lesions, IPMN, and, there are cysts and things like that. But usually the CAT scan itself is pretty good at identifying masses that look malignant. Is that the read was pretty clear on that, Suraj?
Yeah, the final impression, they like said that's suggestive of a pancreatic cancer. I think one thing that we were thinking about is, can abdominal pain present like this? Like, is the pancreatic lesion the cause of these symptoms, or is this an incidental finding? And is the possible colitis that they see the actual cause, and we're just finding this lesion?
Oh,
How do
that's
you
interesting.
navigate that?
So can you just describe a little bit more what they said about the colitis? They said that there was thickening of the bowel wall.
There was some thickening. And there was like some mild fat stranding. And because of the lack of PO contrast, they weren't able to
Exactly.
definitively call
Oh,
colitis. But
yeah.
they said that there could be signs of possible colitis.
So colitis is one of those very vague um, radiographic calls where, especially without PO contrast, it can be hard to see the edges of the bowel wall. And so you have the IV contrast, which is helpful, but sometimes just a collapsed bowel can look thick. So in the context of his clinical scenario, he wasn't having fever, diarrhea. He does not have a white count. Colitis would be like a little bit of a stretch. I mean, obviously, ischemic mesenteric ischemia can give you the appearance of a colitis, but he's not having blood in his stool. There wasn't, like, historically, his symptoms didn't really suggest a colitis. I think I'd be a little hesitant to pin the pain on that. I mean, definitely pancreatic cancer can cause pain once it gets to a certain size, and if it starts to invade the local tissue around the pancreas. So I think it's probably safe to say this is pancreatic cancer causing the pain. But again, some of it is going to be clinical managing him and seeing what happens with the pain. What was done for him right off the bat, Suraj, in the ER?
This goes to our last aliquot. So he was admitted for further workup and pain control, given he was unable to tolerate anything PO.
Yeah.
GI was consulted. They did an upper endoscopy with ultrasound and fine needle aspiration to get a tissue diagnosis of what this mass could be, and the pathology was consistent with a pancreatic adenocarcinoma. His serum tumor markers weren't that impressive. His CA19-9 was 11.1, with the upper limit of normal being 35. His CEA was 16.9, the upper limit of normal being 4.7. And his CA125 was 74.8, upper limit of normal being 35. Oncology was also consulted because of this new diagnosis, and they did staging scans that included the CT chest. That didn't show any signs of metastatic disease in the chest, but on the abdominal film, on the abdominal CAT scan, there was tumor encasement of the superior mesenteric artery and superior mesenteric vein, as well as lymphadenopathy in the peritoneum, and maybe a possible stomach and liver mass. So they thought that this was consistent with metastatic pancreatic carcinoma.
Yeah, that degree of sort of local spread where it's encasing the vessels, there's a lot of nerves and a lot of ways that could be causing pain. So that, I think, is very explanatory of his pain. And then I think, it just goes to show that pancreatic cancer is often diagnosed at a late stage because of the fact that it can be so sort of quiet and subtle as it's presenting. And I actually had a patient in my own panel, I think I shared with you, Suraj, that presented recently, and her symptom was that she described was like, I'm having a lot of gases in my belly. And kind of similarly, she'd lost like 4 or 5 pounds, not a lot of weight, but it was a little odd. Similar story, checked her H. pylori, gave her a PPI, came back a few weeks later, had lost a few more pounds. And I just kind of had this sense that that wasn't quite normal, and did a CAT scan, and she had metastatic pancreatic cancer as well in the tail of her pancreas this time. Usually the head of the pancreas helps you a little bit because it often causes the pancreatic duct to be blocked, in which case you get some LFT abnormalities and bilies elevated. So that can give you a little bit of a clue that that's what you're dealing with earlier on. But that wasn't the case in either of our cases. So pancreatic cancer is unfortunately one of those things we always have to kind of keep in the back of our mind. And if you think about the illness script here, it really sounded very gastric. It sounded very stomach based on his GERD. It's easy to kind of, I don't want to say get derailed, but think common things are common. Gastritis, GERD are, common things we treat in primary care, but kind of always keeping an eye out for the uncommon. And I think the weight loss was the one clue we had kind of early on. But I think even had you checked labs on that initial visit, it probably wouldn't have given you a clue that this was looming in the background. Is that fair? Yeah, go ahead, Maddie.
One question I wanted to ask that kind of brings it back to the primary care setting. So of course, kind of these tumor marker labs were sent to inpatient, but I wanted to ask, are those markers ever sent in the outpatient setting or followed up with in the primary care setting?
Yeah, that's a really good question. This is a hot debate, honestly, in primary care, is like how we should use tumor markers in these settings, and whether it should guide the decision about CAT scans, because I think CAT scans are a great resource. They're also, have harms. So if we were to CAT scan everyone with abdominal pain, that could cause a lot of harm. So we do have to be judicious with imaging. So if somebody has abdominal pain, I think, you know, it's not necessarily wrong to consider using a tumor marker, but there could be a false sense of security also, because, for example, the tumor markers that were sent were not particularly elevated. So, you know, the positive predictive value of the test is something to really keep in mind, and also negative predictive value of the test. So I think you have to be really careful to consider, you know, CA 19.9, CA 125, CEA in these settings. It's not necessarily wrong to send them when you're considering malignancy, but I also think if it's kind of like looking for PE with a D dimer, if your pretest probability is reasonably high based on the history and physical, I think it would be getting those tumor markers in conjunction with imaging, because I think if they're negative, that could give you a false sense of security that there's no malignancy there.
Yeah, that makes
Yeah.
sense. Suraj, what happened with the patient's care and how did they do?
Yeah, so he was discharged after he had a pain regimen. The pain was thought to be due to the extent of the lesion as well as the metastatic sites, and was planned for outpatient oncology follow-up. During that time, because of how advanced the cancer was and locally advanced, they were planning to do neoadjuvant. Actually, it would be more neoadjuvant chemotherapy, see if the cancer had changed in size to the point of being resectable, which is always the goal for pancreatic cancer. But with the goals of care and what was important to his life, he preferred to try to do radiation instead in discussion with his oncologist. And I actually saw him last week in clinic. He's in good spirits. And he's had progressive weight loss. He's got an 85-pound weight loss since this first started, over 1 year. His A1C has come down from 9.6 down to 7.1, likely due to the significant weight loss and pancreatic insufficiency that he might be experiencing. And his pain is much better controlled, and is plugged in with palliative care, as well as with his oncologist.
Did we know if he had a family history? I feel like we skipped over that in the excitement of the case, but just
That's a good
curious.
question. No family history of any kind of cancer or any kind of cancer syndrome.
Got it. Yeah, I think that the advances in pancreatic cancer have been good, although not you know, as good in some other cancers. My patient with a similar diagnosis is being enrolled in a clinical trial, which I'm happy about, but there's still a long way to go with pancreatic cancer in terms of curative treatments for once the stage, and a lot of pancreatic cancer cases are caught at this late stage, unfortunately.
Yeah, and Suraj, I'm really sorry to hear the outcome of this case, but I really appreciate you preparing and bringing it to us so that we can all learn from this patient and how you cared for them. And Suraj, I wanted to ask if you had any reflections on caring for this patient or anything that stuck with you when taking care of this patient, and then I'll pass the mic to Maria to hear any more teaching points she wants to highlight. But first to you, Suraj.
Definitely. I think that the biggest thing that I was humbled by reflecting on was not anchoring early on with the diagnosis. I think the weight loss was a very tricky thing as to how to pair it into his diagnostic framework. Was the weight loss because of the Ozempic or the semaglutide, or was it related to something else that was occult? I think in that first visit, we used the abdominal exam to gauge where the course was going. But I think it was a teaching point for me about diagnostic biases and anchoring and making sure that we keep the differential broad, and using the pretest probabilities to really figure out what are the next appropriate steps. And I think like weight loss in the areas of this GLP-1 receptor agonists are going to be really tough to move forward. And there's like some more reviews recently out there that talked on weight loss and diagnosis of cancer, which I found really interesting as I was preparing for this case, and as the diagnosis also came in real time during during clinic.
Thank you so much, Suraj, again, for preparing this case and presenting it so brilliantly. And Maria, I'll pass the mic to you. And for the physicians and trainees listening to this, I would love if you could maybe highlight three teaching points that you want people to take away.
Sure. Yeah. I think Suraj hit on a really important one, which is, it's easy to come up with an answer for a symptom that you can sort of stop your clinical reasoning after it seems like it makes sense, weight loss on semaglutide. And just keeping that clinical suspicion high for other possibilities. I think weight loss is a really good symptom to focus on because it is an ominous sign. In general, our bodies are designed to gain weight, which is why obesity is such a big problem. So I think it's really important that if someone's losing weight, that is a really important symptom to focus on. And I think the other point here is even though hindsight is 2020, and after you make a diagnosis like this, it can be easy to feel like what was done incorrectly, how should I have done things differently? But we have to practice in a rational way where we make a differential, we think of what's most likely, we think about the patient's clinical picture, and we take things step by step. And even though it feels like in retrospect, oh, I wish we got a CAT scan right off the bat, there weren't any really serious red flags right off the bat. So I think it was actually perfectly reasonable to start with a trial of a PPI. And sometimes in primary care, we can, once we have a diagnosis, we can sometimes look back and think, oh, I should have done things differently. But it is important to think about what makes sense with the information you have and taking a stepwise approach. And that's why we see people back closely to follow up. So I think those are my main points here. I think that this is a really good case to highlight because the illness script of how things present, especially things that are kind of subtle, like pancreatic cancer, is important to get comfortable with so that we do have that picture in our minds of what it's like when people present with subtle cancers. Pancreatic cancer, ovarian cancer is another one that can present in a very sort of subtle way early on.
Thank you so much. Well, I really want to extend a huge thank you both to you, Maria, and to you, Suraj. Really incredible case to learn from, and Maria, really brilliant discussion, especially with kind of how delicately you have to balance kind of caring in the outpatient setting and when to transition to the ED. So I really appreciated the case and your thoughtful teaching. So we'll end the session here, and thank you both so much.
Thank you. This was fun. Thanks, Suraj. Thanks,
Thanks
everyone.
a lot.
Take care.
Bye.